A very good morning to all of you here. It's a pleasant surprise to see people early morning, 9 o'clock session. And that definitely shows that the interest in phakic IOLs is up and rising. I could not agree more with my friend Sonu here. Phakic IOLs are, it's a cliche statement that they're here to stay. In my practice, across all my centers, we made a plan not to buy any more LASIK machines. It might sound harsh. We already have 4, but we don't plan buy any more LASIK machines. We plan to take care of any refractive error with phakic IOLs, oblique clear lens extractions, and other options available. Sounds jarring. It's a disruptive idea, but just wait another few years and you will see this idea working. So I'll be talking about phakic IOLs in general, how to get it right. Because the main game of the procedure is not the surgery itself, but the measurements and sizing. So we have to be knowing our sizing and patient evaluation very, very accurately. My main interest is mainly IPCL. I do a lot of ICLs also, but I think I probably have the largest series in the world in IPCL, nearly 3,000 done, or probably more. So the options available majorly in the market are 2 competitors, the ICL and the IPCL. What would be the exclusion criteria for the patients? Whenever you see a sclerotic cataract, you may miss it. Always dilate the patient and do a distant direct ophthalmoscopy. Early sclerotic cataracts you may miss on slit lamp. Any small evidence of nuclear sclerosis, do not think of phakic IOL or a clear lens extraction. Do a cataract surgery. Corneal dystrophies, low endothelial counts, anterior chamber depth less than 2.8. Again, there's a little small caveat here. Surgeons who are at advanced stage can play around with lesser also. There was some interesting discussion yesterday in another hall where I was doing a session. But I would say the cutoff mark would be 2.8. Any history of uveitis, posterior shiny K, old history of uveal inflammation, think twice. If you have a lens rise more than 600 microns, we will see what lens rise is. Shallow angles, mid-dilating or mildly dilating pupils are a little bit of a semi-contraindication, especially for a beginner surgeon. If your pupil is not dilating well, you can have problems putting in phakic lenses. Very large pupils also are contraindications, semi-contraindications, because you would need larger optic sizes and they're a little tricky to manage. Iris cyst, I've had 3 or 4 cases where I did an UBM only later on to find out that there was an iris cyst here. History of retinal detachment, and of course keratoconus. Keratoconus can be very tricky. Keratoconus can actually give you a very false anterior chamber depth. So you have to watch out for the angles. You have to watch out for a complete gonioscopy, watch the angles, plan a lower vault in keratoconus. Do not get excited and plan a higher vault. In keratoconus, plan a little bit larger optic size because the cornea cone could be a little eccentric. So when you go for a larger optic size, you cannot have a normal vault. Go for a slight smaller vault. So nearly these are cases of combination in IPCL and ICLs. These are the options available in sizes and powers, both in ICLs and IPCL. Of course, as you see, the ICL is a little available in higher powers, though I think I probably have another world record of correcting -38 with 4 diopter cylinder with an IPCL. Also corrected up to -14 diopters of astigmatism. So these are the sizes actually available in both. So if you see on your left, you have size combinations of 4 sizes, and on your right, you have sizes of 13 combinations. So they both have their plus and minus points. I guess when you plan to have a vault which is more forgiving, then you go in for 0.25 millimeter, because there are some issues when you actually plan a smaller vault, but you don't have a large size available. So then you only have an option of 0.5 increment. So there you can fine tune, especially when you're planning toric lenses. In toric lenses, you have to plan a little higher vault because you want the lens to be tighter. You don't want it to rotate. But in a non-toric or a simple sphere lens, you can get away with a lower vault because even if the lens rotates 10, 15, 20 degrees, you don't have a problem. So another trick is when you're planning a toric lens, plan a little higher vault. So for example, every 0.25 millimeter increase in the diameter, the diagonal diameter of the lens, increases the vault by approximately 180 to 200 microns. So you can actually size the way you want. So what are the assessments for the phakic lens? Of course, refraction. Please do a dilated cycloplegic refraction, because you'll be surprised the patient walks in wearing -9, but he's using accommodation. I've had patients who are wearing -8, -9, but their cycloplegic refraction said 5.5 or 6 or 6.5. And they've been used to that. So you need to do a fogging test, you need to do a cycloplegic evaluation, because even these myopes could be accommodating because of a wrong spectacle power given to them over some time. Whenever you have more than 2 diopters of white to white, astigmatism difference between both the eyes, I prefer doing a vertical diameter also. Pre-operative scotopic size of pupil is very important, because then you need to plan in on going for a lens with a larger optic size. When the cornea is large, especially more than 12 millimeter white to white, please confirm the maximum dilatation. If your dilatation is not more than 8 millimeter, this could be slightly tricky for a beginner surgeon. Keratoconus, as I said, be careful. The lens rise has to be measured. Intraocular pressure, disc evaluation, specular microscopy. So these are the various situations I've encountered: healed corneal scars, repaired corneal perforations, keratoconus, piggyback lenses. So these phakic lenses can be used wherever you want. I've used them as secondary IOLs in patients I operated 20 years ago, congenital cataracts or developmental cataracts, and these patients have got big fibrous bags and they have high myopia, -17 with 3 diopter cylinder, anterior chamber is little small. I go in with a phakic IOL and they do very well. So the break points could be always a bad refraction or a wrong acceptance. White to white is the most important concept here. So as Dr. Sonu said, we don't need fancy machines to do that. I will teach you how to do that in the normal setup. In case you have any confusion, throw the data to the manufacturer or the ICL or the IPCL manufacturer, they'll help you. Partially dilating pupils, watch out. Avoid using pilocarpine in patients, especially if you're a beginner surgeon, because this will help you. This will have more of viscoelastic retained behind the IPCL or the ICL. You will have a flatter vault for first 3-4 days, so you will have problems. So if you put a pilocarpine or a miotic in this patient postoperatively, you will get a lower vault than required. I have seen less than 350 microns of vault going down on using pilocarpine. And then at times you get scared what is happening. So do not always avoid using a miotic. If you see minimal opacities behind the phakic lens within the first 2-3 days, relax. This is not cataract. This is viscoelastic. Just do an ASOCT and you will see something white there. Watch out for IOP peaks within first few hours or first few days, and then after 7 days, because you could have steroid responders. So let's go to the sizing. Most important, as I said, is refraction. Measuring of the pupil size is very important, which probably most of the courses are not talking about. This will actually help you to plan your surgery, size your optic size, and also decide what is the kind of viscoelastic you may be using. Pupil size, of course, is, as we all know, the amount of pupil size you see on your measurement is approximately 25% less. So this could be a vague chart you can go by. How do we measure a pupil size? We do a dynamic pupillometry. You could have a Cirrus machine or any other machine which does pupillometry for you. Or you could also use your standard ARK machine to do pupil size measurement. Anterior chamber depth measurement can be done by Cirrus, your Pentacam, your OBSCAN, or even a simple immersion biometry. Just do your immersion biometry or do a central pachymetry on your ASOCT, subtract. I've done a series of thousands of patients. It is just varying between 0.1 to max 0.15 millimeter. Beyond ACD, always check for angle anomalies. Their angles are closed. There are some cysts there. There is some pigmentation there. So watch out for these. If the crystalline lens rise is higher, be careful. If your lens rise is more than 600 microns, plan a higher vault. And if you are planning a higher vault, but you don't have a good ACD, then plan a smaller optic. Because these situations, in spite of whatever you do, even a resting size of a good vault will not stay so, because as time goes by, the lens rise will increase in these patients. So what if your anterior chamber depth is 2.8 or more? Are you totally safe? Well, yes or no. You could have angle anomalies. Your resting pupil size has to be very, very important. If you have a small or a non-dilating pupil, again, watch out. So this is in case, even if you're 2.8 and above, these are the things you watch out for. Look for iris cysts, look for lens rise, keratoconus, posterior synechiae, heel uveitis. So these are the things you walk out. So how do you measure white to white? Most of the people say this is a good method. In my personal opinion, this is only a check method. This should not be a baseline. Use 2-3 methods, only use this to confirm. I have given this test to 3 of my best senior optometrists. Each one of them comes with a different reading. And when I do it, I get a different reading. So this is a good marker for you to know what is the average you're looking at. Always look at the mid-limbal line. You could use a caliper for that, or you could also use an ARK. In fact, in my setup, we found this method far more repeatable between ARKs to do a white-to-white at the mid-limbal. The only requisite is you should have a screen which has got a good resolution. There are some machines out there in the market, probably out there in the stalls also, which we use for this. Planning a vault ideally should be anything between 400 to 750, but then with the present lenses which have central holes, and the IPCL also has peripheral holes, I have even patients who've got vaults up to 1200, 1300, and they're doing fine. So in an ICL, the vault size, usually you can play between 1.5 millimeter. What kind of lens to plan is, again, depends what is the kind of spherical power you're correcting. You can land up in some issues because the powers available are in 0.5. This problem is taken care when you move into an ICL. In an ICL, if I have a toric lens, I go one size larger, the next size. Suppose I need 12.75 for a spherical lens, I will go for a 13 if I'm using a toric lens. Because this 13 will just give me maybe 150 to 180, 200 microns higher vault, but it will make my lens far more stable. This is what lens rise is. You do an AIOCT and draw a straight line from one angle to another angle. The area which rises above this straight line to the crystalline lens central part height is your lens rise. Most of the machines, if you activate in the software, will give you lens rise. Like we use Cirrus in all our centers, so I've activated that button. I get a complete detail of the lens rise and the angle in one shot, and I can actually decide what is the kind of lens vault I'm planning. So please look out for lens rise. Most of the people are not talking about that. White to white trick is if both the eyes have high astigmatism, different astigmatism, then you're okay with more than 0.2 millimeter difference between both the eyes. But if both the eyes have different white to white bit of more than 0.2, recheck again. There could be some pigmentation, there could be some scar on the cornea if you're using an automated method. So please watch out. Anything more than 0.2 is tricky. Planning a larger vault could be, again, this is an important site. So more than 0.2 millimeter reading, watch out the difference. Normally plan 1.25, larger size than what you have. You can plan a small size also, a 0.75 if you're using a large optic diameter. You can also use 1 millimeter size difference, again, depending on the kind of the crystalline lens rise you have. Vertical measurement, if the astigmatism is more than 2 diopters, measure the vertical diameter also. And high astigmatism, high AC depth, please be careful. A keratoconus patient can be very, very scary because you can have all the wrong data and you can have an angle block. I've had so many patients that. And 0.25 millimeter size change will increase the vault to 150 to 180. Thank you.
Thank you, Kamal, for that wonderful presentation. So let's pick up 2 questions. Yes, please.
Fantastic. Okay. When you have an astigmatism, especially if your vertical axis is steeper, remember the lens is not a straight line. It has a width. 6.2, especially if you have a large optic size, 7.2. And most of these cases, high astigmatism, we already plan a large size because I want more area to be covered. So if you have a straight line lens, then just knowing the horizontal is good enough. But if your lens is 6 millimeter larger, I also need to know what's happening here because you could land up with a very high vault if you have a very high astigmatism because the cornea is compressed here. So the lens on the edges is compressed. So you will have an asymmetric vault. You do an AIOCT in these patients dilated. The lens in a horizontal section rises like a tent. So that's how you should know. So that will help you plan your optic size. Yes, of course. See, there are studies which say that the STS and WTW can be corroborative, and sometimes I've done hundreds of cases, and sometimes they totally go haywire. Probably 7 to 8% of your cases where your vault is not going according to plan is, guess what? Your STS is not matching to WTW. So here again, if you know your vertical vault, you can actually plan the size far more perfectly. You see, my target is 84%. 84% of faking girls in my organization are landing within 80 to 100 microns of plan because of such a meticulous workup. So it will always help you because the vertical size, if it's smaller, will add to the vault. Anything more than 2 diopters, please measure the vertical dia. Yes. The lens size is only measured in the center. No, I am using Optopol, so I get a complete 12 millimeter cut section. So 12 meter will give you approximate idea to draw a straight line, and then the lens size is great. Yeah. So I hope you understood. The lens size is important because if you have a high lens rise, do not plan a normal vault. Plan a vault probably 0.25 millimeter higher. Yeah, that's exactly what I'm saying. You know, that's an issue I have with ICL, nothing personal against it, because the range is quite erratic. You just 0.1, you jump and you're 1.5 millimeter higher. Depending on the ACD. If your ACD, okay, again, my cutoff is, if my ACD is more than 3.1, I can play football in the eye. But if it's less than 3, that's where you become a little careful. A higher ACD for more than 3.2 in keratoconus is not a free field for you to play. A higher ACD of more than 3.2 in a large resting pupil size is not your field to play. A higher ACD in a patient who's got 6 diopters of astigmatism, vertical axis steeper, is not your field to play. So these are small points which you all beginners should know, that the clear-cut ACD of 2.8 and above is not your playing field. You have to look out for other things also. I would like to go in for a higher vault, because lower vault, as we all know, as the patient ages, the lens rise goes up. 20 microns every 2-3 years.
So, Kamal,
So I plan a higher vault.
I think this answers her query. Now, do you see this chart?
Yeah.
Do you see this chart? So the moment your white to white jumps from 11.14 to 1.5, there is a change in the size.
So this is what happens.
So you get my point. So the moment your measurement is as small as 0.1, so that is the bridge, you know, and that is where they would ask you to recalculate, reconfirm, you know. So there is a change in the size just for a 0.1 millimeter. And just for the ACD, just take a check of the ACD as well. From 3, so you can have 2 variables. So if I have an ACD of 3, I can either have a 12.6 or a 12.1, but my white to white is what determines the size now. So for both the ACDs, I can have 12.1 and 12.6. Now it is after your experience, then you would then trust whether you want a vault, maybe a lower vault, maybe close to 350 or 400, or you're aiming for a higher vault. Now that is you to decide. Now the dictum has shifted to have a slightly on the higher side rather than going on to the lower side, if you have wide angles. So I think that,
Absolutely.
you know, thank you. Please, I interrupted. So, any more questions for Kamal? We have now, since we are running a parallel national symposium on refractive, and we have the subspecialty on refractive, so we are all having